All right, future nurses, welcome. If the endocrine system ever feels like a super complex puzzle, well, you are definitely in the right place. In this explainer, we're going to break down the key diagnostic tests you'll actually see out on the floor. Our goal? To get clear answers from a system that can be pretty tricky. So let's dive right in.
So this is it. This is the big question in endocrinology, right? A patient comes in, symptoms are pointing to a hormone issue, but is their gland putting out too much or not nearly enough? The entire diagnostic journey, everything, hinges on answering this one simple question. Getting this right from the start is absolutely the key to getting the patient on the right treatment plan.
Okay, so to figure this out, we have two main plays in our playbook. First, there's stimulation testing. Think of it like this. We're basically asking a gland, hey, are you working? We give it a little nudge with a trigger hormone to see if it wakes up and does its job. Then you've got the opposite, suppression testing. This is where we check if a gland knows how to hit the brakes. We give a substance that should tell it to stop producing. If it keeps on going, we know it's overactive.
All right, let's put this theory into action with our first clinical puzzle. This one is all about the posterior pituitary gland and the hormone that controls our body's entire water balance, antidiuretic hormone, or, as you'll know it, ADH. So here we have two sides of the exact same coin. With diabetes insipidus, or DI, you've got a lack of ADH. The kidneys just don't get that signal to hold on to water, so the patient ends up with a massive amount of really dilute urine. Then you flip the coin and you've got SIADH. This is the total opposite. There's way too much ADH, telling the kidneys to hold on to every last drop of water. The result? A very low amount of super concentrated urine.
So how do we prove which one it is? The lab values tell the whole story. In DI, think about it, the patient is losing tons and tons of water. So their blood gets more concentrated, which makes their serum sodium shoot up. Their urine is the opposite. It's like water, very dilute, with a low osmolality. Now, with SIADH, they're holding on to too much water, which dilutes their blood and makes their sodium drop, while their urine becomes really concentrated. The labs really do solve the puzzle for us.
Now, to really nail down the diagnosis, especially when we're trying to figure out why a patient is urinating so much, we turn to something called the water deprivation test. And listen up, because this is a procedure where your role as the nurse is absolutely 100% critical.
Okay, let's walk through this step by step. First, no fluids for the patient while we're monitoring their weight and checking their urine concentration every single hour. Now, once that urine stops getting more concentrated, we check their blood osmolality. If it's high, we give them a dose of synthetic ADH. And that last step? That's the whole point. We're directly testing to see if the kidneys can even respond to the hormone. That tells us if the problem is coming from the brain or if it's the kidneys themselves.
And this brings us to your number one job, patient safety. I mean it. This test is designed to dehydrate the patient, so you have to be vigilant. You're watching for any dizziness, a fast heart rate, any sign of trouble. And here's the critical rule you have to remember. If that patient loses more than 2 kilograms of body weight, the test is over, immediately. Your short buys and quick assessments are what make this whole procedure safe.
Okay, let's move on to our next puzzle. This one takes us to the adrenal cortex and its big shot hormone, cortisol. And guess what? Once again, the core problem is a classic case of too much versus not enough.
With Cushing's, we're dealing with hypercortisolism, just way too much cortisol floating around. Now, this could be caused by the adrenal gland going haywire, a tumor somewhere, or even from long-term use of steroid medications. On the flip side, you have Addison's disease. This is adrenal insufficiency, where the adrenal cortex just isn't producing enough cortisol to get by.
And just like before, the labs are our guide. In Cushing's, you're going to see high cortisol levels pretty much everywhere, in the blood, in the saliva, in a 24-hour urine collection. In Addison's, all those levels are going to be low. But here's the interesting part. Look at the ACTH. That's the hormone that tells the adrenals to get to work. In Addison's, it's high, because the pituitary is basically screaming at a failing adrenal gland, trying to get it to produce cortisol that it just can't make.
Now this is so important. With cortisol, timing is everything. It's not a flat line. It has a natural daily rhythm, a diurnal rhythm, where it peaks in the morning and then drops throughout the day. That's why a single random cortisol level is pretty much useless. We'll often draw blood at 8 a.m. and again at 4 p.m. to check if this rhythm is intact. In Cushing's, that rhythm is gone. The cortisol level just stays high all day long.
So, to confirm Cushing's, we use a suppression test. The logic is actually pretty cool. The patient takes a dose of dexamethasone, which is a synthetic cortisol, late at night. In a healthy person, this fake cortisol should signal the brain to chill out and stop producing ACTH. So the next morning, their real cortisol level should be super low. It should be suppressed. If that level is still high, ding, 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 it tells us the body's feedback loop is broken, and that confirms hypercortisolism. Okay, let's shift gears a bit and tackle two other huge areas. The thyroid, which is basically our body's metabolic engine, and glucose regulation, which, controls our main source of fuel.
A TSH, or thyroid-stimulating hormone, level is usually the very first test they'll order, and it perfectly shows that feedback loop we were talking about. So think of it this way. If the thyroid itself is failing, that's primary hypothyroidism, the pituitary gland starts screaming for it to work harder, so your TSH is high. But if the thyroid is overactive, hyperthyroidism, the pituitary just whispers, so TSH is low. A low TSH could also mean the pituitary itself is the problem, and that's what we call secondary hypothyroidism.
And now for glucose. This number right here, you're going to want to burn this one into your memory. A fasting blood glucose of 126 milligrams per deciliter or higher on 2 different tests is a diagnostic indicator for diabetes mellitus. It is a clear, simple, and incredibly powerful piece of data.
But the best indicator of long-term glucose control is the hemoglobin A1C. Why? Because glucose actually sticks to hemoglobin for the entire life of a red blood cell. So this test tells us the average blood sugar over the last 120 days. It's not about one good day of eating, it's the whole story. For a patient with diabetes, the goal is under 7%. If you see a result over 9%, that indicates poor control, and it's time to take a hard look at their treatment plan.
So we've gone through all these tests. What's the bottom line? What's the takeaway for you as a future nurse? What is your actual role in making sure these diagnostic puzzles get solved and solved correctly?
Your role is foundational. It's everything. You're the one checking for medications that could throw off the results. You're confirming the patient was actually fasting. You're even screening for stress, which can mess with the numbers. You make sure the timing is perfect, that the sample is handled correctly. But maybe most importantly, you are the patient's educator, their support system, and their advocate through what can be a really confusing and scary process.
And that really brings us to our final thought. A lab value is never, ever just a number. Every single result we've talked about today translates directly into a real person's life and their plan of care. So as you go forward in your career, always ask yourself this: what does this number actually mean for my patient, and how is it going to guide the care I provide? Thanks for joining this explainer.